Okay, let's get started today. Today we are going to start another new system, gastrointestinal tract, GIT. GIT. GIT is another very important system that we have. 10 to 15% of the patients' complaints that the patients come to us to the hospital as OP are related to the gastrointestinal tract symptoms and problems. 10 to 15, again, it varies from country to country. Usually it is the 10 to 15% of all hospital visits are second due to the gastrointestinal system related complaints. So now you can just type the complaint that the GIT system involved patient can come to you with quickly. What are the complaints? What are the complaints that, what are the symptoms that they can come to you with? GIT. Vomiting, nausea, good answer. Yes. Go on typing. Pain abdomen, good. Diarrhea, good. Bloating, yes. Distance, cramps, good. Constipation, flatulence. Excellent answers. Your answers are appearing on the screen. Good. Go on. Type some more. Abdominal distension. Bloody stool, yes. What else? Bleeding per rectum, yes. Anything is remaining? No, what are the symptoms? I'm asking you the symptoms. Don't tell me the diagnosis, the symptoms. These are all symptoms that you're talking about. Okay, heartburn. What else? Okay, bleeding per rectum, you have already answered. Bleeding per rectum, you have already answered. Jaundice. Can they come with jaundice? Yes, they can come with jaundice. They can come with mass. They can come with mass, swelling of one particular part of the abdomen. Okay, these are the general symptoms, the complaint that patient comes to you with. Among the students today, we have a internationally renowned gastroenterologist, my dear good friend Dr. Anand Kishore. He is with us from the US. He is in he's a senior gastroenterologist. I think one of these days we'll request him to take a class on one of the topic that he is interested in. So talking about GIT is like taking coal to the Newcastle. I don't want to carry coal to the Newcastle, but then Dr. Kishore, you can correct me if I go wrong anywhere. And I request you to take one class on any of your interest fields. So please let me know. Okay, we'll get going. Though many diseases, there are many hundreds of diseases that the patient can come to you with gastrointestinal system, right from simple functional complaints, functional problems are very common in the gastrointestinal system. Functional in the sense that there is no disease absolutely. Functional dyspepsia, functional flatulence, pain abdomen. When you investigate thoroughly, you may not find any diseases. Right from those mild functional symptoms to carcinoma of the colon, the big spectrum of diseases. Carcinoma of colon is one of the second most common cancer in men after bronchogenic carcinoma. Carcinoma of the colon, all colorectal cancers. So they're second most common causes of cancer in men. And inflammatory bowel disorders, Crohn's disease, ulcerative colitis, ulcerative. These also the little rare, but they are seen in 1 in 2 to 300 people. So these are the roughly the diseases that we acid peptic disease, ulcers, and obstruction, surgical, medical. So abdomen, they say, our professor used to say that abdomen is a Pandora's box. Sometimes the diagnosis is extremely difficult. We may have to even 3 or 4 senior doctors examining the patient sometimes they may not be able to diagnose. So therefore, they say abdomen is the temple of surprises or Pandora's box, they say. Because I think I told you in one of my classes, recently, a couple of months back, we have seen a patient with acute right hypochondriac pain. Right hypochondrium pain, everybody, junior doctors, senior doctors, everyone has seen, even a surgeon has severe acute pain, the right hypochondrium. So everyone was thinking that it is cholecystitis. Anyway, this acute pain in the right hypochondrium, unless proved otherwise, it is acute cholecystitis, calculus or acalculus, whatever. So when we did an ultrasound, to our surprise, the appendix was in a hepatic position. So that was actually an acute appendicitis that was presenting like a right hypochondrial pain and tenderness. So anything can happen rarely in abdomen. So you should be very, very careful. As I'm showing in the diagram, so this is a diagrammatic. Everyone knows about all these things: esophagus, stomach, liver, spleen, gallbladder, pancreas, small intestine, large intestine, uh, and descending colon, and the sigmoid colon, rectum, anus. So it's not like this in the depicted in the diagram. Everything is crumpled and kept it in a jam-packed box. You cannot separate out. That's why surgeons sometimes it may be very difficult for them to locate the proper problem. So it's not as beautiful as we draw on the blackboard or whiteboard. So everything is crumpled like. But for our understanding, this is how it looks: the abdomen and its contents. So coming from the today we'll talk about the few functions, fantastic functions of the gastrointestinal tract. Quickly, physiology and anatomy you all have read in your anatomy physiology days, but just to begin as a opening session, I just wanted to share a couple of anatomical and physiological points that we may have forgotten by now. So esophagus is a pipe, right from the cricoid cartilage. Oral cavity also, we should actually begin with oral cavity, because a lot of oral cavity related diseases also do present to us, like after sulfur, ulcers and fissures and problems in the throat, salivary gland diseases. These are all the upper GIT related diseases. Abscess ulcers are very common, sometimes especially young people just before the examinations related to anxiety. Till now, we don't know what exactly the etiology of abscess ulcer. We attribute to GIT disorders, viral, and then vitamin deficiency and worm infestation. But then there's no specific cause till now, and there's no specific treatment. If they're coming in, they don't require any big treatment. They're all self-limited ulcers, abscess ulcers. So sometimes we may have to give a local steroids application, the ointment base. Right from small issues from abscess ulcer, we go down to esophagus, which is about 25 centimeters long tube that connects the oropharynx at the level of cricoid cartilage till it reaches the lower end of the esophagus, that is the gastroesophageal junction. The total length roughly is 25 centimeters. We have a beautiful peristaltic movements occurring here in related to the food bolus that we take. The food bolus stimulates the peristaltic movements that propels the food down, and the swallowing is a reflex, and it is connected to your brainstem via the sympathetic and parasympathetic nervous system. That's why any patient with CNS disorders, especially brainstem related lesions, brainstem stroke, and all those people, they may have a problem swallowing. So we forgot to mention dysphagia, difficulty in swallowing. Hematemesis are one of the complaints that we forgot to mention in the beginning.